Um, Thank you for the introduction, and we are now going to talk about translating complex surgical cases into high-impact retrospective cohort studies. I'm the moderator of this session. My name is Yvonne Schragen. I'm a surgical oncologist from the Netherlands Cancer Institute in Amsterdam, the Netherlands. My focus is mainly on sarcoma, melanoma, and I'm board member of the ESSO. And today we have two eminent speakers with a lot of experience in complex surgical cases. The first speaker will be Gabrielle van Ramshorst. She's a consultant colorectal surgeon at Ghent University Hospital in Belgium and associate professor at Ghent University in Belgium. She was trained as a fellow at the Netherlands Cancer Institute and the Royal Prince Alfred Hospital in Sydney, and she worked at the Glasgow Royal Infirmary in Scotland. Her main clinical interest is in pelvic exenteration surgery and gynecological cancer and sarcoma. She's involved in several international collaborative projects, and she is chair of the International Committee of the ESSO. And the second speaker, is Dr. Wienan van Hout from the Netherlands Cancer Institute in Amsterdam. His main interest is in sarcoma and melanoma surgery, and he was trained as a fellow at the Mount Sinai Hospital in Toronto and in New York in the Memorial Sloan Kettering Cancer Center, and he worked as a consultant surgeon in the Royal Marsden in London before starting his work in Amsterdam. And let's start with the first talk of Dr. Gabrielle van Ramshorst on pelvic exenteration surgery.
Good morning, good evening. My name is Gabrielle van Ramshorst. I'm a surgeon at Ghent University Hospital. I call myself a surgical oncologist and also an associate professor at Ghent University. And I've been asked to talk about collaborative research models in pelvic exenteration surgery. I don't have any conflicts of interest regarding this topic. And the title of this webinar is Translating Complex Surgical Cases into High-Impact Retrospective Cohort Studies. So my first thought is, well, what's complex surgical cases? Are we talking about rare disease? Are we talking about multidisciplinary surgery, high-risk patients, tertiary surgery? Then high impact. So is that high impact for the patient? Is that local, regional, at national level, international level? Or do we mean publish in a high impact journal? And then the retrospective cohort studies, well, that's multiple. So that's multi-center, repetitive, collaborative. Then you probably need to go national or international, especially if it's for complex rare disease. What about data completeness? And what about research questions? So I'd like to invite you to reflect on my friend Neil Smart, and he always said, by putting the patient first at the heart of what we do, we will never go far wrong. Unfortunately, he's no longer with us, but I think we should keep this in our hearts. Patients who need complex surgery, a few questions to ask. So what is the disease trajectory of these patients? What does it look like? What type of burdens do they experience? What type of complications? What's the impact of that in their daily lives? And then, last but not least, what are the needs of these patients? So, filling the gaps. If you want to set up a study or multiple studies, you have to make sure that you address a research gap, because otherwise, who will be interested in reading it if there's nothing new, right? So the most common one is the knowledge gap. So there's no limited research on your topic. Then there's the evidence gap, that our research contradicts existing research, the methodological gap, empirical gap, or a practical knowledge gap. So there's a disconnect between theory and practice in our topic. A theoretical gap, a population gap, or a data gap. So as long as you can choose one of these gaps and make your case, you can make a case for your study. Why is that so crucial? Well, you need to get together a group of people. So they need to be convinced that there's an actual goal to this study, that it's relevant to the patient, that it's relevant to the care. Maybe it will also be a source of innovation, but that's not necessarily the case. And also, if you can explain why you want to do the study, then maybe you can get some funding, which will be very important for the future. So within surgery or within surgical oncology, there are very different networks and there are different teams. And there are, of course, politics also with editors and journals and associate editors, politics within societies. So you need to have a network to be able to set up a study. And even for us introverts, I would say always go to events and find 3 new people to talk to. And who knows what you'll learn, and who knows how you can help each other, because that's, I think, the collaborative spirit, helping each other. So what are the basic ingredients for a collaborative study? You need to have a dedicated team. You need leadership. You need a protocol which features the right research questions, the right hypotheses, and a statistical analysis plan. And you need an infrastructure. In terms of infrastructure, at least one of the centers needs to be able to create data transfer agreements. So you need to have a legal team present and available. You need to have an institutional review board on board with these studies. And you need to have a data protection officer, because if you're going to be using patient data, you need to make sure that they're well guarded and according to Helsinki principles. And then maybe the most difficult one, you need time. You need time for the analysis, support where necessary. You need time for writing and for chasing people. Because having a collaborative and people not seeing what the output is will make it very difficult to organize future studies. And you need to have a vision. So where exactly are we going with this? What are the success factors for people who are involved? And how do we define success as a group and as an individual? Is that getting funding? Is that building a society or building membership? Is that future sponsoring? Is that more collaborations? Do we want to have an impact on like quality of care, on guidelines, on clinical practice? Or are we doing this for our legacy? And legacy can mean that it will not only cost you blood, sweat, and tears, but some people will also even chip in their own money to get something off the ground, which is very admirable. But nothing happens for nothing. So you need to be sure that you're prepared for that. So I want to give you an example, Pelvex Collaborative. We started collecting data retrospectively, guided by Des Winter and Michael Kelly, as you can see in the picture here, from the period like 2015, 2016. It was an international collaboration. It has grown ever since, with currently 180 centers participating over nearly every continent. And we've had a couple of yearly meetings, and it's been really successful. And what you can, for instance, can see in the graph below, which is from the first publication, Annals of Surgery, is that if you have an R0 resection, which is the top line, the survival over time is much, much higher than an R1 and R2 resections. And not only that, but we also found that if you do a bony resection to do a pelvic exenteration, that survival is about 10% higher. And this is the type of data that will help to build and guide clinical practice. The current number of published papers stands at 22. And as you can see here, and I've written down a couple of these ideas because these can be applicable, applied in many other types of settings. You might need to change it a little bit, but maybe you can use it for your types of surgery and where you want to do a collaborative for. So factors affecting outcomes, systematic review, minimally invasive surgery, palliative pelvic exenteration, Adelphi management strategies, a retrospective study on simultaneous pelvic exenteration liver resection, global costs, perioperative management and anesthesia, etc., etc., etc. And it's still building more. Another example is the Corpex Collaborative. The Corpex Collaborative was founded a couple of years ago and focuses on gynecological malignancies. And as you can see here, this group of which I'm a part, I was very fortunate to be invited, as less than 20 centers from Europe, but the same ideas as the Pelvic Collaborative with a gynae flavor. So again, now the first study, which is just published last November, over 800 patients with an R0 rate of 78%, and this excludes ovarian cancer resections. So that's good to know. And again, for instance, from this type of survival analysis, we can see how nodes in the pelvis of periaortic nodes or negative nodes can impact on the survival. And as you can see here, patients don't do that well. The burden is high and the needs are high too. So it's a great first publication from this group. Another one has just been published about vulvar carcinoma in EGSO. And there are a couple of more papers right now being written with several other centers leading different papers. Gemelli Hospital and Nicolo Bizarri in particular has been really active in getting this done. So what are similarities and differences between these networks? I think the mindsets, the ambition are very similar. It's the same type of surgeon, same type of drive. Of course, the tumor types are different, tumor biology is different, and neoadjuvant treatments are different as well for each tumor type. But most of all, there are many opportunities for collaboration. So what's the type of offspring that you can get from these types of collaborations? So for the Pelvic Collaborative, we're building on outcome reports, prospective data collection. Hopefully, in not too much time, we can do the quality of life questionnaires in a validated way at the same time of time points. There was an RCT which is called PelvX2, which is currently recruiting, which is designed and led by Pim Burger from the Catharina Hospital in Eindhoven. Also part of the same group. There are now protocols for defining re-irradiation protocols, radiology reports, pathology reports, all as offspring from this. There's more consensus about the quality indicators. Societies can be built, bylaws are being designed, board and membership are being developed. And for instance, by defining minimal requirements for pelvic accentuation, you can also influence policymakers within your country to make sure that the centers are well equipped to do so. What we're doing ourselves is a project on sexual health and intimacy after pelvic accentuation, which is sponsored by the European Society for Sexual Medicine. But there's participation now from both the Pelvic Collaborative Group and from Corpex members. So this is a way to bring the collaboratives even together. And hopefully this on an individual level and team level can impact our healthcare providers and to help develop care pathways for our patients. So in conclusion, high impact retrospective studies are feasible. It's a long-term investment in time, dedication, and sometimes even financial investment. The why, the research gap, and the research question are the most important thing. You need to make sure you know what it is. I would suggest that collaboration means being very inclusive, people who want to join, who can join. And I'd like to finish with the words from Neil, like centralize the patient and you can never go wrong. Thank you for your attention, and I'm not sure if I can join for the discussion as I'm traveling, but I hope you have a great day. Thank you.
Okay, I would suggest to save the questions for the end of the session. And I would like to invite Dr. Van Hout, who I introduced in the beginning of this session, to give his talk on complex surgery for retroperitoneal sarcoma. And he's here, I see. Welcome.
Yeah. Yes, I'm here.
Please
Thank
go
you.
ahead.
Thank you. I'm trying to share my screen. And I hear an echo. Wait. Maybe someone needs to mute. No, I don't hear an echo anymore. Good. Okay. I assume you can see my screen. Well, the title of my lecture is Learning from Complex Surgery for Retroperitoneal Sarcoma. Collaboration is key. And today I would like to basically take you on a journey in the development of collaboration within the sarcoma world, especially the retroperitoneal sarcoma world, to see what we learned and how we can learn together to improve the way we treat our patients and to improve outcome for our patients. So thank you for giving me the opportunity to present today to the ESSO, and let's come on this journey. So first of all, a little bit of background to retroperitoneal sarcomas. It's rare. Sarcomas are rare in general, but retroperitoneal sarcomas are definitely rare. Only 1.7 per 100,000 people a year is the incidence. So it is a rare cancer. And for a country of the Netherlands, we have 17 million inhabitants. So the assumptions are that we have between 100 and 150 patients a year annually, totally. So it's a rare cancer. And as you already can see, for those of you who hardly see retroperitoneal sarcomas, the tumors are always rare, always large, almost always large. And they can get up to kilos, from 2 kilos to 10 kilos to 20 kilos. So they can be quite large. So that also means that surgery for retroperitoneal sarcoma is almost always complex, big surgery, almost always open. And in that regard, it's comparable to pelvic accentuations, as we just heard from Gabrielle. So there are many types of sarcomas. There are over 70 different histological subtypes. But when it comes to the retroperitoneum, we mainly see two subtypes. And the first is liposarcomas, and it can be well-differentiated liposarcomas, as you can see here in yellow. They tend to look like normal fat. Also on the scan. And then in red, you have grade 2 or grade 3, so higher grades liposarcomas, and together it's 60 to 65% of all retroperitoneal sarcomas is liposarcoma. And then the second most frequent sarcoma we see in a retroperitoneum is a leiomyosarcoma. And leiomyosarcomas usually in this area derive from veins, so the smooth muscle cells in veins, not in arteries, but in veins. So it could be the renal vein or the IVC or gonadal vein where they arrive from in this area. And then we have some other subtypes, but this covers basically 80 or 85% of all retroperitoneal sarcomas. So as we just heard, it's rare, and there can be many other types of retroperitoneal tumors in this area. So you can see different tumors in these areas, just to show you that retroperitoneal tumors can be sarcomas, can also be other tumors, and that's why we usually advise to biopsy before you do anything. So just to go back to the different subtypes a little bit, liposarcomas, they vary, as I just mentioned, between well-differentiated and dedifferentiated. Quite often you see both a fatty part, and I have another slide on that, and a more aggressive part. So you have to know these tumors before you operate them, because quite often you don't operate enough. And again, I will have another slide on that. And the interesting thing about liposarcomas is that most of them recur locally and do not metastasize. So if patients die, and quite a lot of patients die from liposarcomas, they die from abdominal recurrences and not necessarily distant metastases. And if you operate these patients, usually it requires a complete compartectomy of the whole retroperitoneum, including the organs. But already the things that I mentioned on this slide were not always known. And in the past, many centers did a few sarcomas a year. They saw maybe 1 or 2 retroperitoneal sarcomas a year. And it's very hard to learn if you see these rare tumors and these rare operations just occasionally, and then you can't really learn and improve your outcome. The same goes for leiomyosarcomas. It's a very different tumor than a liposarcoma, also from the origin, as I just mentioned. Usually they are more chemosensitive than liposarcomas, and these tumors tend to metastasize quite frequently. And again, this information became available later on, and I will show you how that worked. So just I think an important slide, surgery is still the cornerstone treatment for these tumors. we hardly have good systemic treatment that replaces it. Quite often it's large surgery, multi-organ resections. And if you look at all literature, 1998, single center, one of the largest centers back then at least, Memorial Sloan Kettering, and Murray Brennan and his team wrote a paper, and they showed that if you do a primary resection for all kinds of retroperitoneal sarcomas, and they were all basically considered the same, then disease-specific survival was 55% after 5 years. Just remember that number because I have a few more slides about 5-year overall survival. So then the world asked, or said, well, the people operating on sarcomas asked themselves the question, how can we improve treatment and outcome of these tumors? So what can we do together to improve? And if you just see a few cases a year, it's not easy to improve. It's much easier if you do colorectal cancer, breast cancer, and you see a lot of cases, it's easier to optimize. But then people all around the world started to ask these questions, and they came together and they realized we have the same questions, and we realized if we want to improve outcome, we can optimize our surgery, maybe do better operations. We need to better understand how this disease works. So the knowledge, the biological behavior, response to therapy. Can we do anything in a neoadjuvant setting, radiation maybe, or chemotherapy? And maybe we need to centralize more to do more cases a year so we have better outcomes. But to do that for a rare cancer, and in that regard, retroperitoneal sarcomas and the collaboration is a very good example for dealing with rare cancers, because if you want to improve all these things, you need to do it together. So you need to collaborate. Without collaboration, there's no way forward, and there's no way you can improve this disease or any other rare cancer. So what can we do? Surgical optimization, can we do it? Well, yes, and I would say the first two important people in Europe that started to think about surgical optimization were Dr. Kronky from Milan and Dr. Bonvalot, she's from Paris. And they considered doing larger resections, more extended resection than just a small resection. And they hypothesized that if you take more organs liberally around the tumor, then maybe we see less local recurrences and maybe we will see a better outcome. And in that moment in time, they did not make any distinction between the subtypes, but they started doing larger resections, and they lectured about this back then. This was in 2012, already 14 years ago. And also they started to change their practice in 2020. I don't remember the day, but at some point in time, they started to change their practice and they followed their patients. And if you see the paper that came out in 29 already, you can see that in the blue line, the patients that they operated in the past, more careful with resecting organs, so smaller resections, compared to after changing practice, the yellow line, where they did more liberal organ resections around the tumors. They saw that the local recurrence rate and was much lower if you did more extensive compartment resections of the retroperitoneum. Also, when they looked at overall survival, they saw a significant difference before and after starting to change the practice in 21. You could see that overall survival improved if they did more extensive resections. And they both saw this, they both wrote a paper, they combined their data, 2 high volume centers, and they built on this. And you could see that overall survival improved from 61% to 50%. And again, we just saw the number of 55% Murray Brennan, which was disease-specific survival. And now even overall survival is better than disease-specific survival with 61%. So there's already an improvement in overall survival if you do better surgery, and if you have a large data set, and if you combine it and show it in 2 different centers. So what does that mean? So if you do a small resection, and a lot of people that don't know liposarcomas, they would think this is the tumor and they take this out. But this is the high grade part. This is the dedifferentiated part, because there's also this more fatty-like, which is well differentiated liposarcomas, which you need to take out as well. And this was been done in the past to take this and take just the tumor, but now we take the organs around it too. So we usually take the kidney, we take the colon. So it's a complete compartment and everything around it, quite often the psoas muscle. And that means a more extensive compartment resection, which can lead to better outcome and less recurrences. So that's what we already learned from collaboration, and this is how it could look like. So a patient with, a large abdomen with a large tumor, if you open it up, and then the tumor comes out, and it can look like this. For those who haven't seen this. So can we do more than just surgical optimization? Well, this is maybe the most important part of my talk. We can increase knowledge and understanding of the disease if we have data and if we have good data. So how can we get more good data? So that's why the TARPSWIC was founded, which is a strange acronym which stands for the Transatlantic Australasian Retroperitoneal Sarcoma Working Group. And it started with 8 centers in North America and in Europe, 8 centers, including our center in Amsterdam. And it expanded to now, I believe, around 100 centers around the world, also in Asia, Australia, South America. And they started to collaborate. And how can you collaborate with such a group? Well, first, you start with meetings. So people came together. This already a while ago, a relatively small group, and it became bigger and bigger, and more people started to join. And now it hardly fits on the pictures anymore because all the people around the world that do something in retroperitoneal sarcomas, they tend to be at the meetings that are at the ESSO and at CTOS, which is a sarcoma meeting in November. And what we did in TARPSWIC is we said we need to pull the data that we have and do a lot of analysis. So analyze, for example, what is the morbidity after multivisceral sections? How can we prevent it? What can we learn about oncological outcome? What can we improve if we know about oncological outcome? And we wrote papers about, what happens if you operate patients that had a local recurrence, or what if you have a second local recurrence and you operate on them, and what is the outcome? And this is how we learned about biology and about treatment, to pull the data and to collect it together. First retrospectively, but now also in a prospective manner, because the TARPSWIC started a prospective database, which started already in 2017, and now more and more centers are part of it. I believe now 25 centers, but way more to come. And together we collect prospective data in the RESAR database to address a lot of questions. So this is how the RESAR database looks like. And there's a website of the TARPSWIC where you can see it. And if you want to be part of this, you can apply for it. And then online, we collect all the data of all our centers. Also, an app was made. It's called a Sarculator, which you can download, which collects the data, which is made by all the data that we collected, just to better predict outcome based on patient and tumor factors, to be able to tell patients what their outcome is. Also, we are part of randomized controlled trials together, so it's easier to do research together if you know each other and collaborate already together. And also, the TARPSWIC group made consensus statements, basically sort of guidelines, how to deal with retroperitoneal sarcomas, and also organizing educational activities to train people and to learn from each other. So these are some of the papers, the consensus papers. This is how to deal with primary retroperitoneal sarcomas, which an update has been made already. This is how to deal with locally recurrent retroperitoneal sarcomas. This is a paper how to deal with metastatic retroperitoneal sarcomas, and also an update is available just now, which we can use together and also for others that are not part of TARPSWIC to learn how to deal with these patients with all the literature that is available combined. Just to go a little bit further, does it really work? What if you have more data, and what if you learn from this disease? Well, you can learn a lot actually. In this paper I want to highlight, this is a paper that came out already a while ago, 2016, 10 years ago, one of the first important TARPSWIC papers. And for the first time, it was a retrospective analysis of 1,007 patients, so more than 1,000 patients with a retroperitoneal sarcomas, which was by far the largest series ever published. And one of the things we learned is that one size doesn't fit all, because if you look at overall survival, there's a huge difference between the different subtypes. If you have in blue a well-differentiated liposarcoma, your 5 years overall survival is more than 90%. While for the bad subtypes, for example, leiomyosarcomas, overall survival is 60%, and for a high-grade D. diff liposarcoma, it's 39%. And it's not even overall survival. If you look at disease recurrence patterns, you can see that the liposarcoma patients tend to recur. This is local recurrence, and you see that basically all the grade liposarcomas recur, and maybe that's the group that might benefit from radiotherapy, while others, for example, leiomyosarcomas, which this paper showed that more than 50% metastasizes, and only the high-grade liposarcoma patients do have a high percentage of distant metastases. Maybe those patients can benefit from chemotherapy, which works systemically. And I think I need to wrap up soon. But just to show what we learned, and that this really leads to a different practice, is that yes, we learn from a large data set, if you work together, that tumor behavior and outcome can vary per subtype. that even your surgical strategy might vary per subtype, because the liposarcoma patients, they tend to recur locally. So those are the ones that might need a compartment resections, while others, like leiomyosarcomas, they don't recur locally so often, very, very low. But the distant metastasis rate is high. So maybe be liberal in taking more organs in liposarcomas and not in leiomyosarcoma patients. And last but not least, your neoadjuvant strategy might need to be tailored per subtype. And just to give you the examples, neoadjuvant radiation, do you need to do it? Well, there has been a study. I won't go into the details. It's called STRASS. You might have heard about this. It analyzed neoadjuvant radiation and surgery followed versus surgery only. The trial was designed before this paper came out, and we knew about the different subtypes. So all the different subtypes were in there, and there was no difference in abdominal recurrence-free survival or overall survival. Although, as you can see, overall survival was already quite high in this subgroup, because maybe only high volume centers participated in these trials, leading to a good overall survival. But based on the data that I just saw, it's not surprising that if you look at the liposarcoma cohort only, there seems to be a difference in outcome if you combine radiation with surgery, the blue line, versus surgery alone, which makes sense if you look at the behavior of the different subtypes. And then last but not least, neoadjuvant chemotherapy. Yes, we do a study right now, it's called STRASS-2, where we do neoadjuvant chemotherapy followed by surgery versus surgery alone. And based on the data that we collected together, that I just showed, we said, if you want to do chemotherapy for this group, only do it for the high-risk group. And what is the high-risk group? Well, it's the group that I just showed, leiomyosarcoma patients and high-grade, so grade 3 liposarcoma patients, because those are the patients that suffer distant metastases, and those are the patients that die from distant metastases. And if you want to have chemotherapy to prevent this, if it can prevent it, then take this subgroup. So based on the data that we collected, this trial is designed to do only the high-risk retroperitoneal sarcomas to do this trial. So again, this is what we do the trial with. It's a global trial. 250 patients are needed and 168 patients are enrolled as of today. And based on the TARPSPIC collaboration, we were able to do this EORTC study for retroperitoneal sarcomas. So in conclusion, collaboration is the way forward for improvement of complex surgery for rare cancers, as we show with the TARPSPIC collaboration for retroperitoneal sarcomas. And I think it's the only way if you want to move forward. You can't do it alone, not even on a national level. Collaborative data collections can lead to improved outcome and evidence-based surgery even. And last but not least, if you want to do randomized controlled trials, and if you want to do it for rare cancers, also then it can only be done together, which is a huge effort, but you can do it if we work together as our ESSO community. And with that, I would like to thank you for your attention.
Thank you so much for your very interesting overview, very impressive. I can't see that there are any questions in the questions and answers section. So I will start the discussion and let's see if something. So I was wondering, you showed us your overview of retroperitoneal sarcoma and the way you collaborated in the world to perform a randomized control trial. So are there any other sarcoma subtypes on which such large collaborations are going on? And of course, performing an RCT is the highest goal in medicine, but are there, could you think of other ways of getting evidence to improve treatment of this rare disease in another way than randomized controlled trials?
Well, thank you for that question. To start with the latter, with your latter question, I think for rare cancers in general and in sarcoma as well, you can't do RCTs for everything because it's impossible. The numbers are too low. And also it is very expensive and very labor intensive to do an RCT, as I know for a fact now. And I think a lot of questions we can address with either smaller retroperitoneal retrospective series or just smaller prospective series or case control studies. And I think that is also important because if we want to learn, we need data. And if we have data in any way we can present it, it can benefit the patients. And Yes, we do stress and stress to the RCTs, but we have many other papers within the TARPSWIC group that gave a lot of valuable information and that people change their practice on. For example, the study that I showed for extensive surgery versus no extensive surgery, it wasn't an RCT, but the data are quite convincing. So I think we should encourage everyone to collect data, even if it's not an RCT, which is quite often not feasible also for surgical purposes. But yes, I do think it can be very, very valuable, especially for rare cancers. And for other sarcoma subtypes, I am not aware of a global collaboration like TARPSWIC like this, but I do know that there are definitely other initiatives, for example, more from the medical oncologists for, as they call, ultra rare cancers, so the very, very rare cancers, to start to collect data together on efficacy of chemotherapy, which I also think could be very valuable, because if you see only 2 patients a year and you don't know what you want to give for chemotherapy, those initiatives can be very valuable. And I hope more to come. So who knows?
Who knows? Okay, very encouraging words. Thank you so much. To conclude, I think we can wrap up this session. What did we learn on those 2 great talks? That collaboration in rare disease leads to prospective data collections and even randomized controlled trials, and all of that will lead to quality improvement to improve the treatment of the patients with the rare disease. And also, I think one of the most important facts that it's also a lot of fun to work together with people all over the world. So thereby, I would like to end this session and thank the organizers and speakers, Clinical Surgical Oncology and ESSO and JMED and GH for organizing this very interesting session. Thank you all for being here today.